Smita, shall I start?
Yes,
Smita, shall I start?
yes, sir. Yes, sir.
Okay, thank you. So, good evening to all of you. In today's class, no, last time I told you about that, I'll be talking to you about the pathophysiology of psychiatric lateral pulsion. So I'll spend 2-3 minutes on that before I go into the case stories. So I'll share my screen now. Is my screen seen? Yeah, okay, then we'll start. What about the pathophysiology of psychiatric lateral pulsion? I told last time, no, there was a case of lateral military infarct where the eyes were deviated to one side, same side. How this is that is possible in lesions of lateral military syndrome? What is the pathophysiology of that? So for that, you must understand that generally, what is the role of cerebellum? Cerebellum is the main center for error correction. For example, to make direct your hand exactly to the target, it should not overshoot or undershoot. Something similar to that is also occurring in the ocular movements. It is a center which corrects your overshooting and undershooting the eye so that it exactly point to the target. So that is a function of the cerebellar control. There are three regions of the cerebellum are involved in the oculomotor control. One is the oculomotor vermis and the vestigial nuclei. The second part is uvula and nodulus, the caudal vermis, and the flocculus and paraflocculus. The latter two contributes the vestibular cerebellum, the floccular and nodular lobe. The other part is the oculomotor vermis and the vestigial nuclei. The function of these two parts are different. The dorsal vermis and the vestigial nucleus, the other is called FOR. FOR means that part of the vestigial nucleus concerned with the oculomotor control. That is the vestigial oculomotor region. That is the full form of FOR. That control the saccadic accuracy, by which mean that saccade is made, whatever is made is a correct saccade. Correct saccade means that it exactly stops at the target, should not overshooting or undershooting. The second part of the cerebellar control is the flocculus and paraflocculus, which stabilizes the neural integrator. What is the function of neural integrator? It provides a step innovation for an adequate pulse. What is pulse? Pulse is the one which shifts your eye from a target, from a point of gaze, to a new target. Okay, that is a pulse. A burst of activity going to the agonist muscles to move the eye to the new position. But it's not enough that when the pulse stops, what will happen? I will come back to the primary position. It is because of the inherent pull of the viscoelastic properties of the orbital muscles. To prevent that, to prevent the pulling backward from the eye, from the eccentric position, there has to be a continuous stream of impulses going to the agonist muscles, even at the end of making a saccade. That is to keep the eye in the eccentric position, should not go back to the primary position. That is by the step innervation. So the step is proportional to the pulse. Proportional to the pulse. So it is the neural integrator which calculates the step, the necessary step for the pulse. So it is responsible for perfect matching of the pulse and step. Now coming to the first one, the dorsal vermis and vestigial nucleus, they modulate the amplitude of the pulse. If the disease will produce hypermetric or hypermetric saccade. How this is made, how this is occurring, I will describe in the subsequent slides. So what is dorsal vermis or vestigial nucleus does is that it drives the burst neurons of the contralateral saccade and provide late break for the ipsilateral saccades. That I will explain in the diagram subsequently. So let us see, this is the right side and left side of the brain, right side and left side of the brain stem. This is abducent nucleus on the left side, which as you all know, supplies ipsilateral lateral rectus, and through the medial rectus supplies the quadrilateral medial rectus subnucleus of the third nerve. So when abducent nucleus get activated, you move towards the left side. This abducent nucleus is driven or burst by the PPR, the paramedian reticular formation, which produces the excitatory burst neuron for the abducent nucleus. The excitatory burst neuron, the PPRF, is again stimulated by the contralateral frontal lobe, frontal eye field. The fibers descend down to the brainstem, cross the opposite side, supply the same side. So this is how the pathway for the gaze pathway. Now, what is this saccadic accretion done by this is done by our vestigial oculomotor region. What does it do? This is on the right side. This vestigial nucleus on the right side is influencing the left PPRF. Okay, left vestigial nucleus influencing the right PPRF. So what does this vestigial nucleus do? It crosses to the opposite side through the hook bundle of Russell and stimulate the PPRF on the other side. So this is apart from the frontal control. That's a voluntary control. But here there is an error correction has to be done. That is done by the vestigial nucleus. So this is the pathway through how the FOR is influencing or correcting the saccade. So what is vestigial nucleus do? See, when it is stimulated, it will naturally going to stimulate the contralateral saccade. So it produces fires at the onset of the contraversial saccade. Already there is a saccadic command from the frontal cortex. Apart from that, It at the onset of the circuit, it fires. Why? It provides an additional push for the circuit to the opposite side. Okay, that's helping the frontal lobe to produce a saccadic movement to the opposite side. Remember, opposite side, not the same side. It also fires towards end of the ipsivasis saccade, that is saccade to the right. End of the saccade to the right, again the vestigial nucleus get activated. So what does it do? So end of the saccade on the right side, it stimulates the left-sided PPRM. Which produces activate the controversy saccade. Why should it act the controversy saccade? So that I should not overshoot on the same side. Suppose you are making a rightward saccade. At the end of the saccade, right vestigial nucleus ensures that that saccade is not overshooting by activating the contralateral PPRM. So it will pull back or stop the saccade on the right side. So what will happen? That saccade is inhibited or not inhibited. At the end of the time, it is inhibited, stopped. So that producing a braking saccade. It breaks the ipsilateral saccade. So the vestigial nucleus stimulate the contralateral saccade, produce a brake for the ipsilateral saccade at the end of the saccadic contraction. Let us see what is happening. There is a lesion of the vestigial nucleus there. See, this is already there by the action of the vestigial nucleus. When that is affected, the activation of the contralateral PPRF is lost. So what will happen? The contralateral saccades are hypometric because of the insufficient push. The initially vestigial nucleus is pushing or giving additional push that is lost. So that leftward saccade become hypometric. Then what will happen to the saccade to the right side? It produces what? A break at the end of the saccade. So what will happen? The break is lost. So what will happen? It will be activated more. So vestigial nucleus lesion on the right side produce a ipsi pulsion. It will produce and it will drive the saccade to the same side. Okay, and decrease saccade to the opposite side. So it becomes what is called ipsi pulsion. Now, in unilateral vestigial lesions, ipsilateral saccades are hypermetric as a result of impaired braking. Why impaired braking? Because it not should have activated the contralateral saccade to produce a brake. That brake is not there, so it will overshoot. Now, this vestigial nucleus is in turn inhibited by the cerebella vermis, produce inhibition. So, what will be the happening with the dorsal vermis? It is just the opposite of what is happening in the vestigial nucleus. So, when there is lesion of the vestigial nucleus, you get ipsipulsion, I told before. When there is lesion of the dorsal vermis, you have to get a contrapulsion. Okay. So this is the action of the dorsal vermis of vestigial nucleus. Now this is how the vestigial nucleus FOR is producing the saccadic correction, so that it makes sure that saccade stops short exactly at the target, it's not overshooting or undershooting. The other part of the cerebellar control is the flocculus and paraflocculus, which as told before stabilizes the neural integrator. When the neural integrator is not stabilized, what will happen? The pulse is there, but the step is leaking. Step will not be sustained. So the eye will drift back to the primary position because there is no input to keep the eye in the eccentric position. So what will happen when the eyes drift back to the primary position? The command is to go to the target. You make a corrective saccade again to the target. So fast compound to the right. Again, there is a slow drift to the primary position because of the insufficient step innervation. So what you get will be a gaze-evoked nystagmus. So this is one. This is the normally this is the pulse. This is a step in. This is a step innervation. Here it is not. Step should be like this normally, but it is leaking. It goes backward. Then there is a corrective saccade backward, and then coming like that. That is a gaze-evoked nystagmus. Now I'll show 2-3 videos of saccadic pulse dysmetria due to the abnormality of the size of the pulse. Also already told this is the FOR region. It can overshoot like that and come back. This is a dysmetric saccade. So unilateral vestigial nucleus lesion results in contralational hypometric saccades, the reason I told before, and ipsilateral hypermetric saccades due to loss of brake for the ipsilateral saccades. So for example, let us see this case of saccadic hypermetria. You look at the eye, it overshoots and come back. And I think skip that thing. It will be difficult to see. So I'll come to the ipsipulsion and contrapulsion. See, this is another case of lateral military syndrome. His eyes are deviated to the left
വലത്തോട്ട്
side.
നോക്കമ്മ, ഇങ്ങോട്ട് നോക്കമ്മ, ഈ വശത്തോട്ട് നോക്ക്, ഇങ്ങോട്ട് നോക്ക്, ഇങ്ങോട്ട് നോക്ക്, ഇങ്ങോട്ട് നോക്ക്, ഇങ്ങോട്ട് നോക്ക്, ഇങ്ങോട്ട് നോക്കമ്മ, അങ്ങോട്ട്
Yes,
നോക്ക്, കറക്റ്റ്. ഇങ്ങോട്ട് നോക്ക്,
very
വലത്തോട്ട്
difficult to
നോക്കിക്കേ,
turn the eye to the right
വലത്തോട്ട്
side,
നോക്ക്,
but it's
ഇടത്തോട്ട് നോക്ക്,
goes on
വലത്തോട്ട്.
deviated to the left side. See, she's already in right. Normally, what is we may think that patient got right-sided gaze palsy, but it's not a gaze palsy. Only because the eyes are pulled towards the left side because eyes are pulsed by the lesion and the inferior cerebellar peduncle. And you can wait out in this after 2 days. This kind of a pulsion disappears rapidly. Now the gaze,
ഇടത്തോട്ട്,
the pull towards the
വലത്തോട്ട്.
left side disappeared and becomes able to look to the right side. Now, how this is made possible in the lateral mental syndrome, how the ipsipulsion is produced. See, as told before, here you can see the dorsal vermis, cerebellar vermis, fascial nucleus here, which through the hook bundle or cell supplies the contralateral PPRM. This cerebellar vermis is actually inhibited by the inferior olive here, which passes through the inferior cerebellar peduncle. Okay. So when there is a lesion here in the inferior peduncle, as happens in lateral mental syndrome, what will happen? The inhibition of the cerebellar vermis is taken away. So cerebellar vermis is overacting. What does cerebellar vermis do on the vestigial nucleus? I told before, it is going to inhibit the vestigial nucleus. So the vestigial nucleus is further inhibited. What does vestigial nucleus do? Stimulate the contralateral saccade. So the contralateral saccade is decreased. So when the contralateral saccade is decreased means the ipsilateral saccade is facilitated. So you get an ipsipulsion. That is why in cerebellar lesion, lateral mental lesion, you get an ipsipulsion. The same thing will also occur. This is inhibited, this will be facilitated. Same thing will also occur in the lesion anywhere in the pathway. For example, if the lesion is in the superior cerebellum, the opposite side, the same thing will occur. But here, contrapulsion, because it's already crossed. So inferior cerebellar lesion, inferior cerebellar peduncle lesion produces ipsipulsion. Superior cerebellar peduncle lesion produces a contrapulsion. Okay, so that's that much about the saccade pulsion. So if the bilateral vestigial lesion get hypermetric saccade, bilateral vermin lesion produce hypermetric saccade. Why hypermetric? Because the main function is the braking system, braking function. The braking function is defective, you get an overshoot. So you get a hypermetric saccade in bilateral vestigial nucleus lesion. How to look for saccade pulsion, which I've already shown in my last class also. As a patient close the eyes and then open. If the saccade eyes are already pulsed, it would have been deviated to the pulsed side. See what's happening here. Eyes are on the left side, deviate left side, come back. We want to look at you, so it comes back to the primary position. So it's got a left-sided lateral pulsion. This lateral mental syndrome. Okay, that much about the pathophysiology of saccadic lateral pulsion. So any questions in that? Last time somebody was asking me what is the pathophysiology of this thing.
Sir.
Yeah. Any
Sir,
question?
Sir,
Please ask.
in acute condition, how to differentiate gaze palsy and lateral pulsion, sir?
Yeah, that is difficult. The easy thing is that keep the eyes closed. Okay, you find that at the resting position, it will be deviated to one side. But this can not be producing problem when he has got an overaction. Okay, in overaction means it will be to the opposite side. That will be difficult in that situation.
Okay, sir.
Okay. Because one is paralysis, the other is overaction. So it is essentially the same thing. But in overaction, how can you find out that the patient is not keeping at rest, it keeps redeviate to the same side? Okay, shall I go to the next case?
Sir, is this the graviceptive pathway, sir?
No, this is not a graviceptive pathway. The graviceptive pathway, if you want to know, I can tell you in the next class. That is for the lateral pulse of the body tilt as well as the skew deviation. the trunk, the lateral pressure of the body, tilt of the trunk, tilt of the body, as well as the tilt of the eye, up and down, the skew deviation are maintained by the graviceptive pathway. Because basically the function of the otolith organ, the graviceptive pathway is from the otolith organs. The otolith organs, what does it do? It maintains the position of the eyes and head in relation to gravity. Okay. So this pathway from the utricle will go to the ipsilateral vestibular nuclei, cross the opposite side, and ascend through the MLF, go to the interstitial nucleus Kahar and third and fourth nuclei, and also go through the thalamus to the cortex, parietal cortex. That the part of the pathway which goes to extraocular nuclei is responsible for maintaining the eyes in relation to gravity. When that is affected, you get one eye up and down because of the ocular counterroll mechanism is defective. The other pathway, the thalamus and parietal lobe is affected, you get a subjective tilt of the subjective visual vertical. You feel that his body is tilted to one side. That is because of again, the loss of sense of verticality because of the pathway is affected. Graviceptive pathway is affected. In fact, for that also I got a lot, I made sort of diagrams for that. If you want, I can talk to you later in another class. But they are different. The graviceptive pathway is different from that producing lateral propulsion. Graviceptive pathway produces a skew deviation.
Can this late propulsion be accompanied by skew deviation, sir, because of
Yeah,
graviceptive pathway?
Definitely, because ultimately it's all crossed together, no? So the only because disease coming from the otolith input is affected, and naturally it produces skew deviation.
Okay, sir.
Okay. Why producing inferior epidemic? That I showed you the last slide, no? The control of the FOR and the dorsal vermis is influenced by the inferior olivary nucleus. That is lost in the inferior in the inferior epidemic. In the case of Lerner syndrome produces skew deviation, the input from the vestibular otolith organ to the vestibular nuclei, that goes to the MLF through the INC. That is lost. The part is all mediated by the vestibular nucleus, but the part concerned is different.
Okay, sir.
Okay. So I'll go to a story of a 27-year-old female. It's a short case. She presented with abnormal movements of the eye, which started in August 16. That is about one and a half months, 6 weeks back. This is a case given to me by Dr. Abhilash. On August 15, she had some itchy sensation on both eyes. She had been having reduced visual acuity for some time and was wearing glasses for the same. No other symptoms. Also, when probed, her husband said that she startles even to smaller sounds that may be significant, may not be significant. So the main thing is some abnormal movement of the eye and some itchy sensation which may or may not be relevant. So this is an eye movement abnormality. That's why this case has been brought. On examination, no other cranial involvement, no motor sensory cerebral signs. Family shares 2 siblings. Younger one also had vision problem and is wearing glasses, otherwise normal. Now look at the eye movement very carefully. Ocular movements were all normal. Okay, what do you think about the eye movement abnormality?
seesaw nystagmus, sir.
Okay, perfectly fine. Very good. So first thing is that it is a what type of is it a jerk nystagmus or a pendular nystagmus?
Pendulars.
Okay, very good. That's a pendular nystagmus because it has no fast component or a slow component, only slow component. Right. Now, what is in nature? Is it a rotary nystagmus or a horizontal or vertical nystagmus?
Rotary, sir.
Rotary. So it's a rotary pendular nystagmus. Okay. So when there is a pendular nystagmus, which can be congenital pendular nystagmus, that's most common, or can be acquired. Acquired pendular nystagmus, commonest lesion is MS in the brainstem lesion in the glenmolar triangle, or any lesion in the glenmolar triangle infarct thing can also produce this thing, and other things, Whipple's disease. These are the things which produces. And other common pendular rotary nystagmus is a seesaw nystagmus. But are you able to make out a seesaw here? It's rotating, but vertical is, are you able to make out?
Sir, when we concentrate on the bridge of the nose, we can able to see.
Okay. So let us say, so this is what I thought, pendular rotary nystagmus. What could be the cause? These are the things. So the patient's already undergone an MRI. This is MRI. There is no lesion in the brainstem. The site of lesion for seesaw nystagmus is classically in the midbrain. The usual cause is cellular mass, paracellular mass lesion compressing on the upper midbrain. So MRI is normal. What is the diagnosis now? No lesion in the brainstem.
Congenital.
Well, very good. Now let us see the same video in slow motion. Now, I want you to look at the root of the nose, not at the eye. If you look at the eye, you may only see the movement only of that eye. But if you look at the root of the nose, and you can see the both eyes moving, the movement of both eyes simultaneously. Now let us play the slow motion video. What do you find now? Look at the root of the eye only. Don't look at the eye. Then you can make out the movement of both eyes.
Now it is like seesaw, sir. One eye is going up.
Yeah. Now you can see the seesaw nystagmus beautifully well. Correct?
Yes, sir.
That is a seesaw nystagmus. See, initially when I looked without slow motion, I was not very sure. But seeing this, I am very sure it's a seesaw nystagmus. So perfect diagnosis. That's a seesaw nystagmus. And the rotary pendular. So this is again showing I made it a little more slow to make it obvious. Now you can make very clearly one eye going up and down. But here the rotary nystagmus is very dominant rather than the upward vertical movement. So what are the features of congenital seesaw nystagmus? I'll tell you a little bit about that thing. Typically, there is intorsion and elevation of one eye and simultaneous extorsion and depression of the other eye. The nystagmus can be pendular waveform. That's the most common thing, classical pendular seesaw nystagmus. For a jerk waveform, the jerk waveform is called hemi-seesaw nystagmus. Hemi-seesaw means that one half is jerk, the other is pendular, slow motion. So it is something like an ordinary nystagmus, except that it's a rotary nystagmus. Rotary nystagmus with a slow and fast component. That is why it's called a hemi-seesaw. But here, the eye moves, in addition to the nystagmus, the eye moves up and down. When the eye indort, the eye goes up. Eye extort goes down. So the usual type is the pendular seesaw nystagmus due to supracellular lesion, can be due to congenital cause. The congenital cause dorsal component may be reversed, or maybe there's no dorsal component. The jerk type is seen classically in midbrain lesion. The pendular form of nystagmus is commonly due to midline mesodiencephalic or bilaterally compressive mass. Two-thirds of the patient's pendular seesaw nystagmus is supracellular or paracellular lesion that compress the midbrain. Most commonly craniopharyngioma and giant pituitary adenomas. What is the mechanism? It is thought to be due to the damage to the interstitial nucleus of heart. located in the mesodiencephalic region adjacent to the medial longitudinal fasciculus. The fibers of the INC project to the oculomotor and trochlear nuclei as well as to the vestibular nuclei in spinal cord. Damage to the INC itself or its projection may lead to unstable vestibular control resulting in the seizure nystagmus. So difficult explanation, whatever it is, when there is a lesion of the INC in the upper midbrain, that will produce somehow some instability of the vestibular control on the eye movement. So I think there are other sites which are reported to produce that thing. I'll skip that thing. Jerk seizure nystagmus, as called hemi-seizure nystagmus, half cycle is pendular, the other half cycle is jerky, mostly due to unilateral lesions of the mesenteric junction. Okay. Now I'll show a similar case again from the given by Dr. Samia. This is a 44-year-old female with history of viral meningitis, not documented in childhood. Initially had oscillopsia, now is symptomatic, no other signs. This is the eye sign.
ডান দিকে তাকাও, বাঁ দিকে তাকাও, উপরে তাকাও, নিচে তাকাও, সোজা তাকাও, আমার আঙুলটার দিকে তাকাও। নাম কি তোমার? এই বাইরে গিয়ে দাঁড়াও, বাইরে গিয়ে দাঁড়াও।
Okay, what is the diagnosis? Simple.
Quick pendular nystagmus.
Again pendular nystagmus, but horizontal. Okay, and it's also congenital horizontal pendular nystagmus because it maintains that same in all directions. So it's a congenital. And often congenital nystagmus is associated with the squint also. Here the patient's got a concomitant divergent squint. Okay. If any questions on that case before go to the next case. Shall we go to the next case?
Yes, sir.
Okay. So this is also a case is given by Dr. Samia. This is a long case. 64-year-old male patient who presented with progressive decline in all cognitive abilities for the last 6 months. Gait difficulties and slowness in the form of slowness in walking. Repetitive disinhibited gestures. Utilization behavior. But I'll show you the video of all these things. Let us interpret one by one the symptom what it is. This is a history given to me by Dr. Samia. Symptoms are subacutely progressive over 6 months. He worked previously in air-conditioner factory. There was no drug history, no history of any high-risk behavior, no other systemic symptoms. Let us each high-level functions, which the video which he has sent me. I have edited it to make you understand it, make it simple. One is the TAP 8 test.
B, C, D, A, G, K, I, L, M, O, A.
So what did you observe? He goes on tapping this irrespective of whatever data is being told. So conventionally tap it is for vigilance. It's absolutely no concentration at all. He goes on tapping it. And what could be the interpretation? A severe defect in vigilance. And maybe there may be perseverative behavior because it's going on doing like that. Because even before hearing this ABC, he started going on tapping it. So maybe an associated perseverative behavior. And let us see the next video. He was asked to draw the numbers in the clock. There is a circle there, and this is how he's drawing outside the circle. Then the water down is he made the numbers on the clock.
শুধু মিনিট আর সেকেন্ডের কাটাটা আমাকে এঁকে দেবেন।
So doctor has clearly written the numbers and he was asked the patient to
আপনি মিনিট আর সেকেন্ডের কাটাটা
arms of the
এঁকে
clock.
10টা 10 ঘড়িতে বাজে
Has shown
সেরকম করে আঁকো।
an arm of the
Minute
clock
or
for a
second
particular time. So what does he do? He's just scribbling outside the outside the circle. So what does this video indicate?
Visual neglect and
No, the
those-
thing is that no, the for visual neglect and all, what should the basic thing should be? What is there? He should have a constant. It should be a combination should be normal. And if you should visual neglect, what will you do? You will not do like that. So he's attempting to draw a clock. One, he has taken the pen outside the circle. That means he is trying to put, but he's put the pen, trying to put inside the circle, but he's taken the pen outside the circle. Point number one. Second, he's not drawing any numbers or arms. Just go on scribbling some line on the outside the paper. That means he has total loss of the concept of the clock. Okay. So this I can show what after giving complete picture of the clock, he couldn't draw that. Possibility one is could be visual disorientation. Why visual disorientation? Because he is taking the pen outside the circle. He is not bringing inside the circle. That means he does not know where exactly the circle is. And he took the pen outside. Ineffective executive function because why? He is provided that his comprehension is normal, which is comprehension is normal in this patient. He is not able to understand the task at hand. That could be that problem. Or even if he is able to understand the task at hand, does not know the concept of the clock. Okay, so only scribbling something. So this is a clear indication of an executive dysfunction.
Can it be ideational apraxia?
Yeah, that's you should ask question. Then I'll make it. In ideational apraxia, what will you do? In ideational apraxia, suppose you does, that video is subsequently coming. Suppose he does not know how to do write or anything, do a particular act. He will not attempt to. He is trying to do that, but he's trying to do it in a wrong way. Okay. On the other hand, ideomotor apraxia, he'll attempt to do, he'll be rowing it in the wrong direction. That's a possibility, ideomotor apraxia. But here what I'm trying to say is that it may be ideomotor apraxia is correctly, that subsequent video will show that. But here he is putting it something outside that circle and then drawing something like that.
So he doesn't have the concept of drawing the clock at all, sir.
That's what I said. He has not lost the concept of the clock at all. He does not make an attempt to try to draw the clock.
Okay, sir.
He cannot comment on agraphia because he did not make an attempt to write. So agraphia cannot be commented upon. I'll show sometimes difficult to differentiate between ideomotor apraxia. That will come later. I'll show them one video. And let us see this particular. What is this? Delirious sequencing task. Yeah. But I want your interpretation. So what do you think?
Executive and perseveration, sir.
Very perfect. Let's go to executive dysfunction because he is not able to understand the task at all in that whatever he's asked to, whatever the doctor has told, he could not understand the task at hand. Second thing, he may be perseverating with the same task. He's going on with the same tapping again and again. So that's perfectly right. So presuming his combination is intact, the abnormality could be due to defective executive function, inability to understand the task or shift to a new task, that is defective response task set, and perseveratory behavior. Perseverance is the first act which he did. And automatic obedience, stimulus boundedness, that is better seen in the next video. So I forget about this. There's a little bit in this particular video, but I'll show the next video. Let us see the next one.
Sir,
Please.
sir, its attention itself is abnormal now, sir.
Pardon?
Its attention is abnormal now, sir.
No, that is difficult to say. What you said is correct. His vigilance is affected. So whenever there is a problem in the attention and vigilance, it is going to affect all your executive functions. But here attention is not totally lost because he is doing something. See, he was taught that you have to do like this, but he's trying to tap that thing. That means he's got some attention is retained. But he's preserved with one particular task alone. The subsequent video also there is attention is relatively okay. It's not perfectly okay, but relatively okay. But that is enough to test some other ML functions.
Okay, sir.
So how to differentiate from Wernicke's appreciation?
That's what he said is perfectly right. If he has got a comprehension problem, you cannot assess any of these ML functions. But here from the history, what is given to me is comprehension is okay. That's what I initially said. Presuming his comprehension is intact, then only this will be abnormality can be given. If he is not comprehending, he is doing something we don't know. But he must have comprehend. There is indirect evidence of indirect comprehension because he is attempting to do that. Otherwise, what you need just staring at you without doing anything. So it's only indirect conclusion, not a direct conclusion. Many times dementia, this is only what is possible. Many times they may not, their attention may be vacillating or waning, or they may be sometimes attention may not attend. This is all big problem in dementia testing. But so to deduce some of the most important finding only by this way. Let us see this particular test, go no go test. He was asked to say, what is go no go test. Let us see.
আমি যখন আপনি টেবিলে হাতটা রাখুন টেবিলে আমার মতো
Listen the video very carefully. Just tap 1.
আমি যখন একবার মারবো তখন আপনি দুবার মারবেন আর আমি যখন দুবার মারবো তখন আপনি একবার মারবেন ঠিক আছে রেডি বুঝতে পেরেছেন আচ্ছা পেনটা ছেড়ে দিন
Just keep back the pen.
টেবিলে হাতটা রাখুন রেডি মনে আছে
So this shows he has comprehended a little bit because the first step did it correctly. When he tapped two times as told by the examiner or by the doctor. Subsequently, it totally went lost. Okay. So he has got one perseverating with that, tapping one hand alone. That is one abnormality. So he's got a severe executive function because he cannot persist with a particular task and he cannot change the one task to another. So what other abnormality did you observe?
Utilization behavior.
Correct. He is tend to utilize the object in the front. See, one defective go-no-go test is an example of a defective response set. Response set means inability to establish a set, maintain a set, and shift from one task to another. That is a defective response test. That is the go-no test is designed for that. And in between, has got tendency to take the pen in between. That is the stimulus-bound behavior or utilization behavior. The stimulus has got a tendency to attract to the whatever stimulus it comes. That is a stimulus-bound behavior. And perseverative behavior towards the end of the task because he's going on doing the same thing. When tap, only tapping on one thing. Now, this is just for testing the prehensile behavior. The patient doctor is asking, showing his hand and ask him not to touch my hand. Let me see.
তুই কমেন্ট করো যে হাতটা কিন্তু ধরবে না
হাতটা ধরবেন না আমার
He's asking not to hold my hand.
হাতটা ধরুন তো
No, this is I got a better video, but that means he's unable to inhibit a motor act. He says, don't not to touch my hand, but he's going to touch. This is called the What is listing is a prehensile behavior. That is a defective response inhibition. Suppose he cannot deviate from an overlearned motor act. See, suppose somebody is showing a hand, take the hand to that direction, but he still know to touch, but he cannot but do that. So this is one of the disorders of intentional programs. So I'll briefly tell about this intentional program because subsequent video also coming to that. So intentional programs provide the corticospinal system with information about when to move. How to move, how to do is praxis. When to move is our intentional problem. It provides instructions about the goals. So intentional program can be when to start a movement, when not to start a movement, when to continue or sustain a movement or posture, when to stop or comprehend the movement. These are all when features come under the intentional programs. When to start a movement, the disease will produce akinesia or inability to initiate a movement in the absence of a corticospinal or motor unit lesion. Hypokinesia is a delay in initiating the response. When not to start a movement, that is defective response inhibition, that is inability to withhold a response to sensory stimulus. Overlearned behavior, you cannot withhold. When to continue or sustain a movement or posture is motor impersistence. That is, you cannot continue with the motor act. Suppose you ask the patient to put out the tongue, keep it like that, he cannot do that. You have to stop in between. He is unable to sustain a movement or posture. When to stop or complete a movement, the opposite of motor impersistence, that is motor perseveration. Even if asked to stop, you continue to do with the motor act, inability to stop a movement or an action program. So what we have seen here, I will not talk about all the things, only talk about what is relevant in this patient. What we have seen is the defective response inhibition, inability to withhold a response to a sensory stimulus. Sensory stimulus is hand, he cannot withhold that, he cannot stop by touching it. They're defined as responding when no response of the body part is required. There are various types, disinhibition or motor area, disinhibited approach behaviors, mid-Gehen, echopraxia. So what we have observed here is one of the example of a disinhibited approach behavior. Now, an example of classical example disinhibited approach behavior is grasp response, suckling and rooting response is a classical example of disinhibited approach behavior. The other examples I will show that. This is the video of this patient. The patient is asked, no, when given a hand, ask him not to touch the hand. He examines his hand.
Don't squeeze me.
Don't squeeze my hand.
Good. Now, don't squeeze me. Whatever you do, don't squeeze me.
Okay, there's got a grasp response.
Put your hand down.
He's unable to put the hand down, which he could not. He go on grasping it.
Relax. Just relax. I want you to put your hand on the table. Don't even let it leave the table. Just keep it there.
It's a grasp
Can you
response.
stop from doing that?
Okay. Then what is mid-Gehen? Mid-Gehen is very slight pressure leads to movement in any direction. It can be tactile mid-Gehen, facilitative paratonia, visual facial grasp, and magnetic apraxia. So I think I'll skip this thing. Facilitative paratonia is opposite to Gegenhalten. Gegenhalten is what? See in a frontal lobe lesion. The patient will put extra resistance for a movement. When you move, patient will extra resistance. Facilitative paratonia is the opposite of Gegenhalten. It will facilitate you the examination. So when the examiner tells the patient to relax the arm, when attempting to check the patient's tone, the patient helps the examiner to move the arm. That is facilitatory, opposite to Gegenhalten. Let us see this patient. Forget about the grasp part of it. See, I'm touching. See, he's put extra effort. I have to put real effort to break it. Then that is Gegenhalten. See, in frontal lobe lesion. See, it's not uniform. It varies with position. It varies with. Sometimes it relaxes. Sometimes it does not relax. Then the other type of mid-Gehen is magnetic apraxia. The patient's hand will approach the moving object that they see and to which they attend. See this particular video showing the hand. He held the hand. The asked to release, he is not releasing the hand. When I take the hand away, his hand is following that hand. like a magnet. Ask him not to touch my finger. Now his grasp has come on it. He's not releasing my hand. Then the hand follows the hand. That is a grouping, or otherwise called a magnetic. Yeah. Here the apraxia is not apraxia normal, even though it's previously called as that thing. It's actually regulated approach behavior, disinhibited approach behavior. Then the third thing is when to continue or sustain movement of posture is impersistence. That is, patient is unable to maintain or sustain a motor act. The classical example, keep the eyes closed for 20 seconds, mouth open. Let's go. This patient is asked to keep her tongue outside for a minute. Put a tongue. If unable to keep it there, it goes inside. Then I demonstrated how I should do that. You cannot maintain the eye closure. I cannot maintain the eye closure. That is motor impersistence. I think when this talks matter perseveration, I think you'll skip all these things. So that's regarding the response inhibition behaviors. Now come back to the patient. Patient is asked to write his name. See where the hand has gone. It's not gone to the pen. Ultimately managed to reach that. Is writing some scribble something, and not in a way it is written. So what are things you want visual disorientation in the sense that he does not know where the pen is, where the pen is. That means going to a different direction. You cannot exactly locate the pen in this space. That is a visual disorientation. Second, probably is phonography also, whether it's there or not, we are not 100% certain. And then he used to draw a wall clock.
আমি আপনাকে কি আঁকতে বলেছিলাম?
See what is he doing with the pen?
কি আঁকতে বলেছিলাম আপনাকে? ওয়াল ক্লক। তো আপনি ওয়াল ক্লক আঁকুন।
How does he? What is he doing with the pen? So how do you interpret this thing? He's asked to draw a clock. This is what he has done. One, you must have not understood the question. Conception, I mean, a combination is defective. That apart from that, it could be what problem? It could be an ideomotor apraxia. He's trying to do, but he cannot do the motor act in the proper way. The sequence cannot be done. It also could be a conceptual apraxia. It has lost the concept of the motor act. It will be difficult to differentiate whether it's a ideomotor apraxia or a conceptual apraxia. To differentiate what should be, yeah, please.
Could be just a conceptual apraxia.
No, it's not a conceptual apraxia because he is not attempting to do that particular thing at all. In conceptual apraxia, he will try to construct something, but he is not doing that at all. It's not like a conceptual apraxia. What does he do with the pen? He is scraping with the pen. He's not trying to write at all. But he's not keeping the pen in the correct position, and he is not doing the correct act of the writing, but he's only scraping just like with your scraping with an object on the floor, on the paper. So the motor act what's done is not the correct motor act. Okay, that can be due to the one problem is the engram itself is lost, because the motor program for writing is itself is lost. That's a concept of apraxia. Other is program is intact, but the program cannot go to the motor innervative pattern, the supplementary motor cortex. That is the true ideomotor apraxia. In ideomotor apraxia, idea is there, concept is there, but it cannot be go into the supplementary motor cortex, which provides the motor innervative pattern. How to differentiate is that if you got to show how you can ask him to show that the way you're writing, what are you doing now by showing that? If he says to tell that you are writing, that means his concept is intact. Otherwise, it's difficult to differentiate between conceptual apraxia and ideomotor apraxia just by observing what the patient is doing. Have you understood what I said?
Yes, sir.
Yeah, okay.
আমি
Yeah, any other question, please? Okay. So the way he held the pen, he did the writing, he was scraping. And this last video, see, he's analyzing this one. He's on the key.
কি এটা
See what he's
Lock.
doing with the hand.
এটা দিয়ে লক খোলে
He recognized the object.
এটার নাম কি এই জিনিসটা
Not able to tell the name.
কি এটা কি চাবি আচ্ছা এটা দিয়ে কি করে এটা দিয়ে
See the way he would,
তালা
he
খোলে
knows what he has to do with that, he does, he knows.
ঠিক আছে
So what does it mean? He has recognized the object but not able to name.
এইটা কি কি এটা দেখতে পাচ্ছেন এটাকে দেখতে পাচ্ছেন তো এটা কি বলুন
He is perseverating with the previous act. Initially he was doing how the key should be manipulated, that is repeating with that.
এটা কি ওয়াচ তো কি করে এটা দিয়ে হাতে পড়ে
So he's got a normal aphasia. He could recognize the object but shows no conceptual apraxia. Because he did the apraxia is intact because he knows the action did it correctly with the key. And the recognition object is also intact because unless you recognize the object, you cannot do the act of the opening, the rotating movement of the key. So he shows the action of the key. The second part, when the watch was shown, he was precipitating with the previous behavior. He's again doing the same thing with the watch. So that much about the high mental functions. So which are the part of the brain affected will come later on. The subsequent examination he is fine.
আমার দিকে আসুন হেঁটে হেঁটে আসুন আসুন আসুন
Great initiation difficulty, slowness in walking, loss of arm swing. The previous video also you can see it's got a mask-like patches.
আসুন আসুন আচ্ছা একটু উল্টো দিকে ঘুরুন তো উল্টো দিকে ঘুরুন
ঘুরুন পিছন দিকে ঘুরে যান বাবা ঘুরে যান এদিকে হেঁটে আসুন সোজা হেঁটে যান আসুন
আসুন আসুন আর একটু হেল্প করুন
So, what is the gait like? Parkinson's because it's mask-like facies, short step, narrow-based gait, preset pursuit. So, less likely to be a frontal gait disorder because of the affection of the upper limb and the narrow base and the flexed posture of the hands and trunk. So, this is a Parkinsonism. So, what is the likely site of lesion and the probable etiology? It's got bilateral prefrontal dysfunction and parieto-occipital dysfunction. What are the features of prefrontal? Both dorsolateral prefrontal as well as orbitofrontal. What are the symptoms due to dorsolateral prefrontal? It's got a severe executive dysfunction, perseverating behavior, and inability to task at the hand. Again, this exemplifying the, substantiating the executive dysfunction. What is the evidence of orbitofrontal dysfunction? It's got utilization behavior, prehension, and the so-called stimulus-bound behavior. No, it's got a bilateral parieto-occipital, it's got a visual disorientation, anomia, ideomotor apraxia, and agraphia.
Sir, dominant parietal we can say, sir.
Pardon? Dominant? And I
So
didn't
all
get you.
ideomotor apraxia, agraphia, everything can come under dominant parietal. Why should we invoke bilateral, sir?
Yeah, your point is correct. But he has got a visual disorientation, a visual indication that usually It is bilateral parietal occipital, more of a non-dominant.
Okay,
Because
sir.
he cannot unable to localize the space, object in the correct space.
So he has both cortical and basic ganglionic problem.
Yes, of course. Yeah. Perfect. It's got, in addition to this, so it's got a hemispherical frontal parietal lesion bilaterally, as well as Parkinsonism.
Sir, did he have any dystonia, sir?
I didn't find difficult to comment about dystonia. Whatever we could see was he's got a rigidity and slowness in walking, muscular equation. Abnormal posturing we couldn't see.
Okay, sir.
So what could be etiology? We do not know what. There are many things. Can be vascular Parkinsonism. It could be something like a DLBD. It may be degenerative disease like CBS, FTD overlap because of the parietal lobes and dementia part. Or chronic infections like HIV, neurosyphilis, autoimmune, paraneoplastic, non-paraneoplastic. Right? These are the things which one should keep in mind. In fact, I thought these possibilities. There may be others also which you can, even mass lesion also you have to keep in mind, but almost symmetrically makes it less likely for a mass lesion. And Parkinsonism in mass lesion is also uncommon. Hydrocephalus can produce, but hydrocephalus, it don't produce features of Parkinsonism in the sense that it only produces lower body Parkinsonism. Your upper limbs are affected, mask-like facies, those things will not occur with an NPH. Bifrontal dysfunction producing a frontal gait disorder. So what do you want now? And adult onset leukodystrophy, these are the things you have to keep in.
MRI
So
brain.
Okay, MRI brain, let us see the MRI. So look at this is the MRI done, short flare sequence. Actually, one by one. This is look at the flare sequence. It's got hyperdensity in the subcortical white matter adjoining in the ventricle, corona radiata, and in the lentiform nucleus. This is the diffusion restriction is there in this patient. Again, the same area where the flare showed hyperdensity. This is the diffusion film. This is the T1, which is essentially normal. This is the T2 again, showing the same abnormality as the flare. Okay, so he has got bilateral putamen involvement, identified nucleus involvement, subcortical corona radiata, trigonal region in the periphery, subcortical white matter, all are in. But the U fibers are spared. This is showing that is actually not a shine through, it's a diffusion restriction. And J is normal. So, what are the possibility now? Very unlikely for a multi-infarct lesion because it's symmetrical involvement. Something we have to think of a degenerative neurometabolic disease or a toxic conditions which can produce symmetrical involvement. Okay. Duration actually, this case is given by Dr. Samia. I think it was about 2 years duration. 6 months duration. Sorry, 6 months.
CJD.
Rapidly progressive.
CJD.
But it's not a CJD. CJD will not produce a predominant involvement is the white matter. But there's no cortical ribbon sign.
Sir, SWA film, sir. SWA film available, sir.
Pardon?
SWA.
SW, this is not given. This is the only film given to me. SW picture is not there.
Sir, any HI?
Yeah, that's another important condition is HIV infection can put exactly something similar to that. But there is one key point which again is got a diffusion restriction in the same area, which shows hyperdensity in the T2. I'll tell you what condition is. So EEG was done, which is normal limits. CSF protein normal, glucose normal. The other investigations, LFT, RFT electrodes normal. Serology was negative, so unlikely for a CNS neurosyphilis. Then neuroviral autoimmune and paraneoplastic antibodies was negative. CSF VDRL was negative. Anti-TPA was normal. Parasitic workup was negative. CSF and JC virus was pending. And the FTG PET was done. That showed multiple non-FTG ill-defined lytic changes noted in the involving multiple dorsal lumbar vertebrae. Just forget about that. So in the lung, and the whole body PET is not showing any clear abnormality like a tumor or anything. No definite PET evidence of clinically significant abnormal hypermetabolism is noted elsewhere in the body in the present study. So what do you think?
So some leukodystrophy, sir.
Correct. Some kind of
So,
see when you get a symmetrical white matter hyperintensity, you think of a leukodystrophy. Some leukodystrophy can occur in the adult also.
Sir, but
So,
basal ganglia is involved, sir.
pardon?
Basal ganglia is involved. Lentiform nucleus is involved.
Basically, I say of involved. Yeah, it's also involved. So leukodystrophy does not mean only confined to the suprabite matter. It can affect the cortex. It can affect the basal ganglia. All can be affected. The predominant thing will be in the subcortical white matter. Predominantly subcortical frontal dysfunction plus dysfunction, parietal dysfunction plus Parkinsonism. The clue is that symmetrical white matter hyperintensity. It says leukodystrophy or HIV. HIV also can present like that. HIV is unlikely because his HIV was negative. And another clue is that there's a persistent vision restriction. Okay, now let us see. There are adult onset leukodystrophies with persistent diffusion restriction. There are many, 2-3 conditions. One is CSF1R related leukoencephalopathy, neuronal intranuclear inclusion body disease, AARS2 related leukodystrophy. So, see, these are things which we don't really come across. I have not seen I've seen a case of neuronal intranuclear inclusion body disease. I have not seen the other things. Only by literature evidence. I mean, I read about it only. That's otherwise I have not seen. But these conditions can present with the diffusion. I'll show the pictures later on. Can present exactly like dementia, late onset age can go up to 70 years. That can progressive dementia, can have Parkinsonism, and MRI abnormalities mimicking this. So I will also show one other case because that is related to this particular case. This particular case I have shown some time back. Most have forgotten about it. Anyway, I'll go through that because it is somewhat related to that present problem. It's an old case of diabetes for the last 20 years and hypertension for the last 20 years. 12 years back, he had one episode of loss of consciousness with fall while traveling in a motorcycle. He did not apparently have any head injury, but remained unconscious for next 1 hour. On recovery, he did not have any weakness or any of the complaints. That is 20 years back. He had another episode of loss of consciousness lasting about 5 minutes while he was admitted for hip replacement 2 years back. No history of any tonic-clonic phenomena. Post-ically, he did not have any neurological deficit. He just lost consciousness. A third episode of loss of consciousness occurred 2 months later, lasting for about 1 hour. Again, he did not give any history of any seizure or post-ically neurological deficit. In July 23rd, that is 6 weeks prior, while walking, he fell down with loss of consciousness lasting for 1 hour. He did not wake up for next 12 hours. Ultimately, he woke up with no deficit. On 2nd September, that is 9 days prior to present admission, when he woke up in the morning, he noticed inability to get up from bed. He noticed total inability to move both his upper and lower limbs and his artery. Wife noticed facial deviation to right side. So many episodes of loss of consciousness lasting for minutes to some of hours, and one episode of deficit with quadriparesis and facial deviation. The weakness of one side, right side, improved in 1 hour. In another 5 hours, he improved totally. No sequelae after recovery. Even though he had quadriplegia, no sequelae after. So this is the patient. I have not spent time. His person is perfectly normal. Ocular muscles, everything is normal, not even wrist reflexes. Okay. What do you think about the diagnosis of this patient? Is hypertensive and diabetes. Actually, you want to think of it, maybe TA, no?
Basilar ischemia, sir.
Yeah, that's the one thing we should keep in mind because we're in quadriplegia and facial lesions and all. But it seems funny that he remained unconscious many times for 6 to 5, 6 hours and all. No? Quite funny without any sequelae at that time. Anyway, that's the nearest possibility which we can think. So he was admitted in the local hospital, investigated. This MRI is the first MRI. MRI done in the previous hospital after the last episode of cortic paresis. This is the MRI. This is the diffusion sequence. It's got middle square peduncle hyperdensity. And look, if you look at the subcortical white matter in the U fibers, the corticomedullary region, and look at the splenium also showing hyperdensity there in the diffusion. And look at the hyperdensity just like something like a ribbon in the corticomedullary region. You can make it out very clearly here also. Some diffusion restriction. Here there is a large area of diffusion restriction. There may be an infarct, but other areas got something symmetrically occurring in all throughout. Again, you can make out the hyperdensity in the subcortical corticomedullary region. ADC was not contributory. Flare, not much except that there is hyperdensity in the subcortical white matter. Not very prominent, but the diffusion restriction was very prominent. The splenium shows hyperdensity here. Again, subcortical hyperdensity is there adjoining the ventricle. And you can make out the then SWI. No evidence of any blooming anywhere. MR angio, perfectly normal. Other investigations done in that hospital, the blood parameters normal, LFT, those things were normal. He was a diabetic, HbA1c was 8.8, RFT etc. normal, lipid profile, okay, slightly elevated to 86 abnormal. And they did an echo which showed that echo was normal, and there is a Holter showed a single episode of non-sustained ventricular tachycardia. Used abdomen normal, audiogram normal, minimal hearing loss. So what do you want? What do you think?
Some genetic vasculopathies.
Correct. Genetic vasculopathy is a very good, like a cadacil, agreed. But cadacil is the appearance in the cadacil. Will it show diffusion restriction subcortical matter? Classically, it shows hyperdensity in the anterior temporal lobe, external capsule, apart from subcortical.
Mitochondrial Leigh disease.
Leigh disease is a possibility that usually affects the basal ganglia, the globus pallidus. That is not affected here.
Can it be press?
No, this is a long history, recurrent episodes of loss of consciousness. And this is not the picture of it. It's a symmetrical affection like a ribbon. I'll show that. No, I did not know what the diagnosis was. Frankly, then I discussed with my radiologist. He thought of the diagnosis. So I asked,
Clark said that cytotoxic lesions of corpus callosum, CLOCC.
See, even this chloride channel deficiency you are talking about? I don't know.
No, sir. Cytotoxic lesions of corpus callosum, CLOCC, we have. It might be due to metronidazole toxicity. There are multiple reasons for splenium of corpus callosum and rostrum of corpus callosum to be involved, sir.
Dude, I don't know that condition. Is it some genetic disorder?
No, sir. It is an imaging diagnosis, sir, but
Imaging
etiology.
diagnosis. Yeah, okay, imaging diagnosis. So, this imaging finding was classical or something. That I will tell you that thing.
Okay, sir.
So I want an imaging, MRI angio to be done because recurrent episodes occurring. I thought that was done. That is perfectly normal. CT angio I did. This is a CT angio. Then I repeated the MRI. Let us see the MRI now. See the diffusion film. See the MCP hyperintensity there. Bilateral, symmetrical. You can see the cortical substance like a ribbon-like diffusion restriction surrounding all throughout in a symmetrical fashion like this, and a splenial hyperintensity. That is a MCP hyperintensity. This is again the same thing which I just at the window with.
Polyglucosan disease. We can think of.
Pardon?
Polyglucosan disease we can think of.
Yeah, adult polyglucosan, but that is not diffusion restriction like this.
Okay.
That can also present like this, multi-system involvement. But they don't present like episodes, stroke-like episodes. They do not present like.
Okay, okay, sir.
So this is the flare sequence. That area is hyperdensity. There's another infarct here in this area. But the main lesions are in the periphery. This is the T2 again showing the MCP hyperintensity bilaterally. That one. That is the diagnostic clue, apart from the diffusion restriction.
Fragile X.
Yeah, but it's a variant of fragile X, correct? This is the SPW. But the presentation is like FRX is like a fragile ataxia. Fragile ataxia is a classical tremor ataxia syndrome. There's no tremor, no ataxia, and progress. He's got episodes. But you got a point, I'll come to that later on. This is the MRI angio done, everything normal. So this is the clues, MCP hyperdensity. Then similarly hyperdensity in the crus cerebri and the superior epidural. And in the cortical, the subcortical white matter like this, like a ribbon-like hyperdensity. So that is an infarct. Splenial hyperdensity. This is again, see the way the restriction is occurring. T2. So the condition, this is what is reported it is. See, acute infarct, forgot about that. Areas of diffusion restriction with corresponding flare abnormalities involving bilateral frontoparietal white matter, the corticomedullary junctions, corpus callosum, bilateral MCP, to evaluate for neuronal intranuclear inclusion body disease and fragile X associated tremor syndrome after excluding toxic leukoencephalopathy. Okay, so what this is the NIID. So it's a progressive, I'll tell you something about that thing. It's a neurodegenerative disease carrying pathologically eosinophilic, highly intranuclear inclusions in the central and peripheral nervous system and multiple visceral organs. I think forget about the genetics and all. But what is more important, look at the clinical picture. They got 5 distinct types. One, they present as cognitive impairment, dominant type, that is a 34.1%. Second, see episodic neurogenic event dominant, episodic events, just like our patient. Third is movement disorder dominant type and autonomic dysfunction type, neuromuscular type. These are the type. The classical one, our patient had the presentation was like episodic neurogenic event. What are the events I will tell later on? And look at the characteristic MRI finding. Hyperdensity in the corticomedullary junction in non-DWI. Focal cortical edema and enhancement. White matter lesions involving the paravermis, Mills-Villa peduncle, and corpus callosum. High signal in the cortical junction in the DWI have been described as a pathognomonic MRI finding of NIAD. And they can present like stroke-like onset encephalitic attacks. This is the case report. So this is the type, one of the presentation is episodic neurogenic event dominant type. How do they present? Let us see. Disturbance of loss of consciousness, unconsciousness. Acutely developed reduced ability to focus attention, even loss of consciousness, lasting for several hours to days, and may be resolved spontaneously without any specific treatment, just like our patient. They can present encephalitic episodes can present, and stroke-like episodes. Our last person was a stroke-like a vertebral of stroke. Acute neurological deficit mimicking stroke in the absence of infarction lesions indicating vascular distribution or vascular stenosis imaging, or can present epileptic seizure like episodic headache. And they usually show a skin sample should show intranuclear inclusions in circle lines. This is from the literacy. This is the classical picture one cannot mistake. This our patient had. The corticomedullary region, the diffusion restriction like this. This is from the literature. So what do you want? I want a skin biopsy. And a characteristic MRI is fitting with that. Skin biopsy reveals intranuclear inclusions that can be labeled with antibodies to ubiquitin.
Inclusions.
Yeah. However, the presence of intranuclear inclusion, however, may be indistinguishable from changes in the fragile X chromosome.
Fragile X అంటే ట్రెమర్ అటాక్సియా ఉంటుందంట.
Fragile X syndrome can also demonstrate a similar pattern of high DW signals and paravermin lesions similar to that of NIAD. It is therefore recommended that the NIAD tested for Fragile X chromosome gene premutation. So I did a skin biopsy, which was normal, which did not show any inclusion in body. So a genetic test was done. The Fragile X chromosome panel was done. That is positive, a Fragile X chromosome. No, it is not Fragile X chromosome disease as such, but it is akin because there is a tremendous overlap in the imaging parameter of Fragile X with NIAD. This is the chart we're showing that. See, ataxia syndrome. Fragile X associated tremor active syndrome is late onset. Forget about that. It's one of the most common single gene forms. Has a broad spectrum of symptoms ranging from relatively severe disease in mid-adulthood to mild case of being late in life. A typical case of Italian woman who had several proximal episodes. So this particular Fragile X has got a proximal episodes as to acute cerebral administrative dysfunction. I think this is a stories and all. Now this is an article. Fragile X chromosome difficult to differentiate from NIAD through skin biopsy because it may or may not be present in both the conditions. So in fact, it is the same genetic abnormality manifesting in different way. When they have got a clinical presentation of tremor and ataxia, we call tremor attack, Fragile X syndrome. The other thing you call it as NIAD. Almost same findings as that of NIAD. Exactly same. Pardon? So I think I'll skip these things. These are the CSF1R related leukodystrophy. They can there is otherwise called ALSP, adult onset leukoencephalopathy, axonal spheroids, pigment and glia. This is the MRI pattern. This is the way they show diffusion restriction here in CSF1R related leukoencephalopathy. Then there is ARS related leukoencephalopathy. That characteristically has ovarian failure. Again, you can find diffusion restriction here. I think I'll skip those things. This is again ARS2. I think there are some differentiating features within the radiological. I'll skip those things. Okay, so that's about these things in leukodystrophy. So when you get a symmetrical white matter abnormality consider leukodystrophy, one of the possibility it can present even in old age, up to 70 years can present. And there are three conditions which present repeat restriction. One is ALSP, second is NAAD or a fragile X chromosome overlap. Third is the this thing, A8, the other one, AARS2 disease. Anyway, this is all rare conditions because only brought because I had a case like that. Because what the Samia's case also looks very much like that of a leukodystrophy. That particular genetic test was done. Unfortunately, that did not come to be, did not give any diagnosis. So, any questions?
Anything to offer as treatment, sir?
The patient which I had, I don't know what to do. I put him on antiplatelets and center. What can we do? Nothing can be done. Okay. Any questions? No, these cases are not, we don't come across that regularly. Just because Sammy had bought that case, I thought about presenting the other case also. With this particular case, I presented some time back. The fragile X chromosome.
Yes, sir.
NAAD. I did not think about that. My radiologist thought of that possibility. Okay, shall we call it a day?
Okay, sir.
Any questions?
Thank
Okay,
you.
good night.
Thank
Okay,
you,
good
sir.
night.
Good night.
Good night. Good night. Good night.
Thank you, sir. Good night.
Thank you.
Thank you, sir.
Good night. Thank you. Good night. Good night.